Okay, so today's lecture is going to revisit some adrenergic pharmacology, and we're going to focus specifically on the alpha antagonist. Although the objectives are pretty straightforward, we're really going to focus on alpha-1 antagonists in the context of BPH. And so for the treatment of BPH, there's really two and a half maybe drug classes. The last one here, these phosphodiesterase inhibitors, they can work, but the clinical data is not that overwhelmingly convincing. The main treatment approaches, and they're listed kind of in the order of importance, include the alpha antagonists, and these are alpha-1 specific antagonists. So these are the SINs, prazosin, terazosin, etc. Tamsulosin and silodosin are also in that same category, and we'll talk about the nuances between those drugs in the next slide. The other group of drugs that are important are the aromatase inhibitors, specifically flutamide and I can never say this one, dutasteride. And then finally, we'll revisit the phosphodiesterase 5 inhibitors. The one that's been mentioned, at least in terms of a clinical trial, is tadalafil. They haven't done all of the phosphodiesterase inhibitors. And of course, these are the Viagra, Cialis, Levitra type drugs for erectile dysfunction. So let's start with the alpha antagonists. And so we initially talked about them very briefly in the hypertensive lectures and cases and so forth. They're not really mainstay therapeutic drugs for hypertension, although they can be used. The key differences between all these drugs is that they're ordered basically by historical precedence. Prazosin is the oldest one. All of them can be used for BPH. Some of these other older generation drugs, prazosin, terazosin, and doxazosin, also have the added benefit of hypertension. If the patient is a male patient with BPH and hypertension, these are great drugs to treat those patients. These are a little bit more improved drugs. They have less, even practically zero affinity for alpha-2 receptors. The bulk of all the drugs on this category have extreme affinity for alpha-1. And these are the most potent, and these work actually very well for treating BPH and some of the symptoms. I do want to remind you that we had talked about alpha-2. Remember, anatomically, a little bit different. These are mostly prejunctional, and these are inhibitory type of receptors. We're not going to talk about these in this lecture. I just wanted to kind of remind you. I'm sure all of you are in the step preparation protocol. So when we talk about alpha receptor antagonists, the only really ones that are clinically useful are the alpha-1 antagonists. And so we had talked about alpha-2 back in the day. The prototype alpha-2 agonist is clonidine. The prototype alpha-2 antagonist is yohimbine. And that's pretty much all I'll say. We'll focus here on the alpha-1 receptor. This is a post-junctional receptor. It's a G protein coupled receptor. It's found in blood vessels, skin, mucosa, sweat glands, the radial muscle of the eye, and of course the prostate, which was kind of the focus of today's lecture. They are stimulatory through a GQ subunit. They increase inositol triphosphate, and that produces a sustained smooth muscle contraction. The prototype agonist that we had talked about way back when was phenylephrine, but the prototype antagonist, which is the focus of this lecture, is prazosin. Now, move this over so the animation is stopped. Alpha-1 agonism, when you stimulate alpha-1 receptors in smooth muscle, you produce, as I said before, muscle contraction, and that's sustained through inositol triphosphate and diacylglycerol. And here's the chemical pathway right here. Of course, when you supply an antagonist, it fits into this binding cleft. I'll move the animation right here. And essentially, the smooth muscle contraction is reduced, and you get smooth muscle relaxation. And that's kind of the whole focus of these drugs. Also, since we are reviewing a little bit of step preparation, when we talk about alpha-1 receptors, alpha-1 receptors have relatively equal affinities, more or less, to norepinephrine and epinephrine. slightly more norepinephrine. And that's just basically because these these receptors are in the periphery, and they encounter norepinephrine a little bit more frequently. The affinities for all of the different adrenergic receptors are summarized here. I made this this slide or this diagram, and I can't remember if I ever handed it out to you guys, so I decided to include it in this lecture, more or less for review. It's nothing really to focus on for this lecture. Of course, the focus is primarily on alpha-1. Understand that in the smooth muscle vasculature, the relaxation and the contraction paradigm is essentially controlled by beta-2 receptors and alpha-1 receptors. We had talked about this. The difference being the affinity for those two receptors with comparison to epinephrine and norepinephrine. Of course, at low levels of epi, you get smooth muscle relaxation, primarily through epinephrine hitting those beta-2 receptors, and this is kind of your rest and digest phenotype. When the tiger is chasing you and you need to run, now all of the epinephrine sites are basically bound on the beta-2 receptor because of the higher affinity. Lower affinity alpha-1 receptors, and also the fact that they're more numerous, produces a real nice sustained muscle contraction to really kind of get the blood moving and to get you away from the tiger that's supposedly trying to eat you. This is basically what this looks like in terms of a vessel size. And so, during smooth muscle relaxation, we get nice open patent vessels, of course, and then during contraction, we get constricted vessels, which leads to, at least from the pathophysiologic component, leads to hypertension. When you add a drug such as prazosin on to this paradigm, of course, you basically get, that's the next slide, you basically get a reduction in the contractile response, and that's basically the mechanism of how prazosin can control hypertension by basically antagonizing the effect of epi and to some extent norepi on these alpha-1 receptors within the periphery. And so that's prazosin as a antihypertensive agent. Of course, we're kind of focusing on BPH because of this particular lecture, but I thought it's a good way to review these drugs. I always remember it's a sin to go against alpha-1. That's where you can get the prazosin, tauruzosin, and doxazosin drugs. From a mechanistic standpoint, we're going to vasoconstrict those peripheral vessels through antagonism of that alpha-1 receptor. I showed you just that mechanism a few moments ago. Clinically, we can reduce blood pressure and control hypertension. We can also treat BPH. The side effects are listed here. Orthostatic hypotension is probably the most commonly asked side effect. It also includes the first dose phenomenon. Typically, patients, when they first take this drug, they get an orthostatic hypotension because of this persistent alpha blockade, which leads to, of course, reflexive tachycardia. And sometimes the patients have a problem with the baroreceptor reflex, and when they stand up abruptly, they pass out. So more on that mechanism in terms of alpha-1 antagonism and its ability to control BPH. So here we're looking at alpha-1 blockade, which alleviates benign prostatic hyperplasia via basically two mechanisms: relaxing the smooth muscle of the prostate gland and the neck of the bladder, and a reduction in the resistance to the outflow of urine. And so the reason this works is because the sites and the density of these alpha-1 receptors are quite high. So within the prostate gland and the lower urinary tract, there's actually a lot of alpha-1 receptors. Likewise, there's a lot of alpha-1 receptors within the arterioles and the veins. So in terms of the side effects that we had just discussed, typically we said dizziness and lightheadedness is a major side effect. The remedy for that is to tell the patient to take these drugs at night, just before they go to bed. Syncope and fainting also can be problematic as it perturbs the baroreceptor reflex, and we can tell the patient to basically slowly stand up. And so the classic story is like the patient's laying on the couch, the doorbell rings, they jump up, and then they pass out. We should instruct them to slowly change positions over the course of maybe 30 to 40 seconds. Put both feet on the floor, sit up in the upright position, and then slowly get up so that they don't fall and pass out. Patients that also have BPH with erectile dysfunction, most of the drugs, and it's the older generation of the drugs, they cannot be taken together with nitrates. The exception would be tamsulosin and alfuzosin. Those are specifically okay to take with sildenafil. All right. This is just kind of a nice summary diagram of the alpha receptors. I wanted to give this out to you guys for review. Really, what we're only really talking in today's lecture about this wing right here. But if you're thinking, oh, what's an alpha-1 agonist, what's an alpha-2 agonist, and so on, these are the distinctions and the clinical uses of those. All right, let's take a break here, and we'll pick up in a few minutes.